Welcome to this explainer. Okay, so when a patient rolls through the doors in a catastrophic neurologic crisis, we all know the saying, right? Time is brain. But you know, one of the most immediate and honestly heavily debated vitals we have to manage right out of the gate is blood pressure. Getting it right literally saves lives and preserves function. But getting it wrong, well, the consequences can be absolutely devastating. Let's get into it.
So here's a question for you. When does lowering a patient's blood pressure actually harm their brain? It feels a little counterintuitive, doesn't it? I mean, in emergency medicine, our gut instinct is almost always to normalize vitals. We see a sky-high blood pressure and we instantly want to fix it. But in neurology, we run straight into what we call the perfusion paradox. Our instinct to lower that high blood pressure isn't always right. In fact, depending on the specific emergency, aggressive intervention can actually destroy the very brain tissue we're trying so hard to save.
All right, here's our roadmap for today. We're going to cover the brain's balancing act, acute ischemic stroke, intracerebral hemorrhage, preeclampsia and systemic emergencies, and finally, traumatic brain injury.
Section 1. The brain's balancing act.
This really sets up the central conflict we face in all these crises, the Goldilocks perfusion principle. Think of it like walking a tightrope. On one hand, you absolutely need enough pressure to push blood and oxygen into a damaged brain, because if they're hypoperfused, that leads straight to ischemia and cell death. But on the other hand, excessive hypertension, that can blow out weakened vessels, worsen bleeding, and cause fatal swelling. So we're constantly searching for that just right hemodynamic zone. And as you're going to see, that target zone moves dramatically depending on the exact pathology we're dealing with.
Moving on to Section 2, acute ischemic stroke, or AIS.
So AIS accounts for a whopping 87% of all strokes, and up to 75% of these patients are going to show up with elevated blood pressure. But here is your absolute critical threshold to remember, 220/120. If your patient is not a candidate for intravenous thrombolysis or endovascular therapy, guidelines actually tell us to withhold antihypertensive therapy completely unless their blood pressure crosses this massive number. Crazy, right? But why? Well, it goes back to what we just talked about. The brain is desperately trying to autoregulate and force blood past the clot to save that ischemic penumbra. If you step in and aggressively drop the pressure, you literally starve the brain.
But, and this is a big but, the rules completely flip if the patient is receiving intravenous thrombolysis, or IVT. If you're gearing up to push those clot-busting drugs, you absolutely must bring their blood pressure strictly below 185/110 before you give them medication, and then you've got to keep it below 180/105 afterward.
And this quote brilliantly illustrates exactly why that strict cutoff exists. Just look at this staggering observational data from the SITS registry. It shows a fourfold increased risk, of symptomatic intracranial hemorrhage in patients with systolic pressures over 170 compared to those kept in the 141 to 150 range. So post-IVT blood pressure control, yeah, it's definitely not just a polite suggestion. It is a strict necessity to prevent hemorrhagic transformation.
All right, Section 3, intracerebral hemorrhage, or ICH.
Now here, our clinical objective completely changes. We aren't trying to preserve an ischemic penumbra anymore, right? Instead, we are desperately trying to stop active bleeding inside a closed box. So the crucial takeaway here is understanding this stark contrast. In ischemia, observational studies show us this U-shaped relationship, where both extremes, too high and too low, cause harm. But in hemorrhage, the vast majority of hematoma expansion happens within the first 3 hours. Lowering blood pressure rapidly is literally your primary weapon to prevent that hematoma from growing. The Goldilocks principle demands a completely different, way more aggressive approach for this one.
So that begs the question, just how low should we go? Well, clinical trials have given us some heavily debated nuance on this. The INTERACT trial found that intensive lowering to a systolic below 140 reduced hematoma growth safely, which sounds great. However, the ATCH2 trial, which pushed for an intensive target using nicardipine, actually found no functional benefit and, to make matters worse, showed an increase in renal adverse events with that intensive therapy.
So the sweet spot we learned on today, based on the current evidence, is lowering systolic blood pressure to less than 140, but keeping it greater than 110. And the absolute key here is extreme time sensitivity. You really want to initiate this treatment within 2 hours of ICH onset and hit your target within 1 hour to effectively minimize that hematoma expansion. The clock is ticking on this one.
Now,
When it comes to IV agents, as you'll see here, you need really careful titration for continuous, smooth, and sustained control of that blood pressure. The goal is to avoid peaks and large variability at all costs. First-line agents like nicardipine, which is a calcium channel blocker, or labetalol, a beta blocker with alpha-1 antagonism, these are going to be your absolute go-to choices for that nice, steady, smooth descent.
Moving right along to Section 4, preeclampsia, PRES, and RCVS.
So these are unique and honestly often overlapping systemic emergencies that require their own distinct diagnostic awareness. For preeclampsia specifically, prompt diagnosis is everything. You're looking for that combination of severe blood pressure elevations. We're talking a systolic of 160 or higher or a diastolic of 110 or higher. And then you pair that with either proteinuria or new-onset hypertension with severe features, things like thrombocytopenia, hepatic dysfunction, or pulmonary edema. You can confirm these vitals in just minutes, which is great because it allows you to expedite treatment fast.
And when it is time to pull the trigger and treat, ACOG guidelines actually indicate there are no significant efficacy differences among the primary choices. Labetalol starting at 10 to 20 milligrams IV or hydralazine at 5 to 10 milligrams IV are both standard, highly effective regimens to quickly get that pressure under control.
Now, for conditions like PRES, which really requires managing those underlying triggers alongside BP control, or say when you're discharging a low-risk TIA patient from the ED, transitioning them over to standard oral agents is absolutely vital for long-term prevention. Some common options include lisinopril, an ACE inhibitor, or losartan, an ARB. Getting these on board and coordinating with their outpatient providers reduces those recurrent stroke risks significantly.
And our final section, Section 5, traumatic brain injury.
When trauma is introduced into the mix, the hemodynamics present some pretty terrifying new challenges. Just listen to this. A single episode of hypotension was associated with a 2-fold increase in mortality. Just let that sink in for a second. When the brain is traumatized and intracranial pressure spikes, cerebral perfusion pressure completely plummets. If the systemic blood pressure drops even briefly, you instantly starve that traumatized brain of oxygen, and that leads directly to catastrophic secondary brain injury.
The EPIC TBI study, which was this massive analysis of over 12,000 pre-hospital cases, confirmed this perfectly. They found that mortality rises sharply when systolic blood pressure falls below 90. So the data clearly proves that avoiding hypotension is absolutely critical here. In fact, the lowest adjusted mortality was actually observed in that slightly elevated systolic range of 130 to 180.
Okay, so let's tie all of this together into a rapid-fire cheat sheet you can just mentally pocket for your next shift. Ready? For ischemic stroke without lytics, permissive hypertension. Don't even touch it unless it's over 220 over 120. Ischemic stroke with lytics, you must be below 185 over 110. For an intracerebral hemorrhage, get it between 110 and 140 quickly but smoothly. Remember, no peaks. Preeclampsia, treat anything over 160 over 110 rapidly. And for trauma and TBI, avoid a systolic under 90 at all costs. You want to aim for that 130 to 180 sweet spot.
Which leaves us with this final thought. Managing blood pressure in a neurologic crisis, it isn't just about pulling out a one-size-fits-all drip. It's about knowing exactly what pathology is unfolding inside that skull and precisely matching your hemodynamics to it. Take a look at the protocols in your own emergency department. Do they actually empower your team to effectively differentiate and target these distinct numbers for ischemia, hemorrhage, and trauma? It's a complex balancing act for sure, but mastering it is quite literally what saves the brain. Thanks so much for joining me on this explainer, and keep learning.